This week's focus is on the peripheral vascular system, and careful assessment is essential for the detection of disease of peripheral arteries and veins. Peripheral artery disease is generally defined as an atherosclerotic disease distal to the aortic bifurcation. Unfortunately, it roughly affects 8 million Americans, with the prevalence increasing as age increases. Detection of peripheral artery disease is important because it's both a marker of cardiovascular morbidity and mortality, and it's certainly an indicator of functional decline. Risk from death from MI and stroke is tripled in patients with peripheral artery disease. Let's do a brief overview of the anatomy and physiology of the arteries and veins. Let's start with arteries. We know that they respond to variations in cardiac systole and diastole that's generated by cardiac output. Anatomy and size really vary according to the distance from the heart. There are some arterial pulses that are palpable, and that is afforded when the artery lies close to the body surface. In the arms, we're talking about the brachial, radial, and ulnar arteries, and in the legs, the femoral, popliteal, dorsalis pedis, and posterior tibialis. The anatomy of the veins reveals that they're thin-walled and highly distensible. Deep veins carry about 90% of the venous return from the lower extremities, and they're very well supported by their surrounding tissues. The superficial veins are located in the subcutaneous tissue, and it's really poor support. The deep superficial and perforating veins have one-way valves, so that in those extremities, and they propel the blood toward the heart, preventing pooling, venous stasis, and backflow. You'll often see people with incompetent valves, and there's issues with that and circulation. We'd be remiss not to go ahead and look at the anatomy of the lymphatic system, which works with our peripheral vascular system. There's an extensive vascular network that drains lymph from the body tissues and returns it to venous circulation. Lymph nodes are round, oval, or bean-shaped structures. They vary in size according to their location. They have a huge role in the body's immune system. The cells in the lymph nodes engulf cellular debris and bacteria, and they produce antibodies. Only superficial lymph nodes are accessible to physical exam. Some common or concerning symptoms that are identified in the health history related to peripheral artery and venous disease include complaint of pain in arms and legs, intermittent claudication, cold, numbness, pallor in the legs or hair loss, swelling in the calves, legs, or feet, certainly color change in the fingertips or toes in cold weather or with a temperature extreme. Maybe your patient is a meat cutter at the local grocery and has to go into the cooler. Swelling or redness or tenderness. Some particular questions we need to ask related to peripheral artery disease is about the intermittent claudication, and I think it'd be appropriate to ask them, have you ever had any pain or cramping in your legs when walking, or when exercise? Does the pain get better with rest? An arterial spasm in the finger and toes. Do your fingertips or toes ever change color in cold weather or when you handle cold objects, or if they're exposed like I gave you in the other example? Venous peripheral vascular disease, really specific questions about swelling of the feet and legs, and also ask about ulcers on the legs, and often near the ankles. The other thing I would ask is if they have ever had any stasis dermatitis. When you're considering health promotion and counseling related to peripheral artery disease, you have to keep in mind that most of our patients have no symptoms or non-specific symptoms. There is a triad of exercise-induced calf pain that causes the patient to stop exercising, and that patient experiences relief of pain in 10 minutes. And unfortunately, that's only present in about 10% of the affected patients. So we have to be vigilant to screen for subclinical peripheral artery disease, and also really aggressive risk factor intervention. You have to identify the risk factors and then aggressively intervene. One of the diagnostic tests that is helpful to detect stenosis of 50% or more in major vessels is the ankle brachial index. And I'd like you to go over how to measure that and calculate it. Look at those normals for ABI, 0.90 to 1.30, and then review your mild to moderate disease and your severe disease with critical stenosis of that ankle brachial index. So what are the techniques of examination that are specific to peripheral vascular system? Well, we definitely have to inspect the arms and the legs. You're looking for size and symmetry and skin color. You're checking those pulses that are close to the body's surface, and that's why anatomically you have to know which ones are. And then looking at the information on the arms, don't forget to include the epitrochlear lymph node assessment. And then legs, we're doing very much the same. We are also including inguinal lymph node assessment and looking for and assessing for peripheral edema. Need to inspect both arms from the fingertips to the shoulder, looking for size, symmetry, and any swelling. Venous patterns, color of the skin and nail beds, textures of the skin, and then palpate for the radial pulse. This tells us to use our finger pads on the flexor surface of the wrist, partially flex that patient's wrist, and compare the pulse in both arms. You need to palpate the brachial pulse by flexing the elbow slightly and palpate artery medial to the bicep tendon in the antecubital crease. The epitrochlear node can be assessed by flexing the elbow at 90 degrees. You support the forearm and feel in the groove between the biceps and triceps muscle, about 3 centimeters, a little over, an inch above the medial epicondyle. Technique of examination of the legs, you should have the patient lying down, draped, so external genitalia is covered and legs are fully exposed. You got to remove the socks or the stockings. Inspect both legs from the groin to the buttocks to the feet, and you are looking again for size, symmetry, swelling, venous pattern, venous enlargement, pigmentation, rashes, scars or ulcer, color and texture of the skin, color of the nail beds, distribution of hair on the lower legs, feet, and toes. Be sure to palpate the superficial inguinal nodes, both the horizontal and vertical groups. Note the size, the consistency, the discreteness and tenderness. Non-tender discrete nodes up to 1 to 2 centimeters are palpable in normal people, so you might find some discrete nodes. Going to palpate pulses, the femoral pulse, the popliteal pulse, the dorsalis pedis pulse, and the posterior tibial pulse. Now, the information on the slide tells you exactly how to do it. I think as RNs that we are skilled at assessing pulses. It's very important to accurately grade the amplitude of arterial pulses, and just review this chart with 3+ being bounding all the way to 0 absent or unable to palpate. Again, as a matter of review for assessment and examination for edema, you're going to compare one foot and leg with the other. You're going to note relative size and prominence of veins, tendons, and bones. Check for pitting edema. Remember, press firmly with the thumb for 5 seconds over the dorsum of each foot and behind the medial malleolus and shins. Severity of edema is graded on a 4-point scale, slight to very marked. If you do discover edema, look for the causes. Recent deep venous thrombosis, chronic venous insufficiency, lymphedema. Note the color of the skin, local area of redness, brownish area near ankles, ulcers and where they're located, and the thickness of the skin. Some special techniques in assessment is if you want to evaluate the arterial supply of the hand, if you suspect arterial insufficiency. So you're going to, again, thoroughly assess the radial, branchial, and ulnar pulses. You're going to perform Allen test. If chronic arterial insufficiency is suspected, the patient has complaint of pain and diminished pulses, check for postural color changes and evaluate competency of venous valves. Assess retrograde filling through the Trundleberg test. This question, it just helps us clarify what are the signs and symptoms of venous insufficiency. So a patient you're seeing comes complaining of a sore in his lower leg that does not seem to get better. Based on your examination findings, you do suspect venous insufficiency. Which of the clinical findings would suggest venous insufficiency as a cause of his problem? A, leg discomfort is exacerbated by dependency. B, hyperpigmentation is present around the lower calf area. C, ulceration is present on the medial side of the ankle. D, affected leg feels warm to touch. Or E, all of the above. The answer is all of the above. Leg discomfort is usually exacerbated by dependency. There is hyperpigmentation is present around the lower calf area. Ulceration is present on the medial side of the ankle, and the affected leg feels warm to touch. Final question really wants you to focus between arterial insufficiency and venous insufficiency. So we just reviewed the signs and exam findings of venous. So arterial, you're seeing a patient that complains of severe pain in her right foot. Based on your findings, you suspect arterial insufficiency. Which of the clinical findings below would suggest arterial insufficiency as a cause of her problem? A, brisk posterior tibial and dorsalis pedis pulses. B, pallor of the foot upon elevation. C, pitting edema of the lower leg. Or D, warmth of the right foot. The answer is B, pallor of the foot upon elevation. You would anticipate to find decreased posterior tibial and dorsalis pedis pulses, no edema of the lower leg, and actually the right foot would be cool. The other thing I would say is if we're comparing ulceration, I typically find that arterial ulcers are very painful and venous ulcers are not. Thank you for your attention.